Assalamu alaikum. I'm Lotus Maarouf. I'm a second year medical student, and today I will be giving you guys the adrenocortical hormones lecture. Now, I must preface this by saying that this lecture is quite lengthy. Even I, as a second year, as I was preparing for it, I realized that there's a lot of content to cover. So definitely do take your time when you are studying this lecture, because I'm not going to say it's difficult. I'm just going to say that it requires time, because it could get confusing when you start getting into the bits and details of basically the physiology. And you won't regret it, honestly, because this is one of the concepts that you'll definitely see on exam day. Not even one or two questions, it's going to be most of the exam. That's how we had it. That's how probably you guys will have it too, because it's a very staple concept. So without further ado, let's begin. And another thing is, don't forget, even after you've understood, let's say, the slides or whatever, make sure to go over practice questions. And I'm not saying past, because past sometimes misses things because it's just students remembering the questions. So go through the book questions, understand it at a level from a textbook, the questions at least. I'm not telling you to open a textbook, and then go through the past papers. But definitely make sure to have ample practice so that you're ready for the questions during exam day. Now, first of all, I want to begin with a quick recap of the adrenal glands. What are they? They are these two paired glands that sit on top of the kidney, the retroperitoneum. They have their own blood supply. You guys all know that from anatomy, I'm hoping. And we don't really care about the anatomy here. What we're talking about when we're dealing with the adrenal glands is that while it is one gland anatomically, functionally it acts as two glands. The reason why we consider it two glands is because it is derived from different areas embryologically. So we have the cortex, the adrenal cortex, this area outside, and the adrenal medulla, which is inside. Now, they come from different embryological sources, making them have different functions. So the adrenal cortex comes from the embryonic mesoderm, while the adrenal medulla comes from neural ectoderm. Now, neural ectoderm, I think that you can reckon by now that it has almost like a neuron-like function. It's not a neuron, but it acts like one. And this is why it's always named as a modified sympathetic ganglion, which means that it can release its own hormones. It can act like the sympathetic chain. Even the adrenal medulla and the sympathetic chain have the same type of cell that acts in them. So yeah, and it releases epinephrine and norepinephrine. This is just very brief. We're going to be going into it, into details. We have a whole section for the medulla. Now let's talk for now about the adrenal cortex. As you guys may or may not know by now, you have three layers: the glomerulosa, fasciculata, and reticularis. Now, a way I like to remember it is GFR. It has nothing to do with the GFR you guys know from renal, but you know, it could get confusing when you're overwhelmed with information. So this is the layers from outside to inside. Again, you have the capsule overlying the cortex. It will keep the blood supply, lymphatics, whatever it may be, close to the cortex or close to the gland. And we're not really concerned with it. What we're concerned with, again, is the layers of the cortex. Now we have the glomerulosa, and it will be like specializing in the production of mineralocorticoids. Now there's multiple mineralocorticoids, and we will be discussing them. But when we talk about mineralocorticoids that the glomerulosa does, we're mostly concerned with aldosterone. It's the main mineralocorticoid, but keep in mind, it's not the only mineralocorticoid that this layer can create. Okay, so yeah, aldosterone. And again, one thing that I'd like to mention is that because it's creating aldosterone, this means that it has all of the enzymes necessary to create aldosterone. And because it's specializing in creating aldosterone, this means that it has specific enzymes that are only found in this layer to allow it to create aldosterone. Now, if you notice for fasciculata and reticularis, they have some minor functions of other steroids. So for example, fasciculata, it creates cortisol, which is the major glucocorticoid. Yeah, it's a glucocorticoid. And the other one is corticosterone. Again, it's not the only glucocorticoid, but when we're talking about major, I want you to think of cortisol. Now, for reticularis, it's DHEA, Reticularis secretes gonadocorticoids. Now, I used to confuse between gonadocorticoids and androgens. A good way to think about it is that gonadocorticoids are just weak androgens. What are androgens? They're male sex hormones, weak male sex hormones. They don't have much of a function in the adult male. They do have a function in an adult female because, again, for females, it's estrogen. And the androgenic function would be from a weak androgen, not testosterone. So it would be DHEA, and another one is androstenedione. We're going to be talking about them later. But again, main one is DHEA. And again, I said in an adult male, notice how I said that, and adult female, because for both males and females in very early development, I'm talking embryologically and quite early, like at birth, uh, these hormones, gonadocorticoids, play a very essential role in the differentiation and in characteristics that we will see in males and females. So during development, it's very essential. So if you have something that's congenital, a congenital deficiency in DHEA production, or enzymes that go through the DHEA production, then you are going to see a specific set of symptoms, or let's say presentations. We're going to be discussing them in a bit. And again, this is not something very major that the fasciculata, it mainly creates glucocorticoids, but it also has some androgenic activity or creates some gonadocorticoids. It's not its main function. Again, that's something I want you to keep in mind. Just keep this at the back of your mind, remember it, and we are going to discuss the relevance of this in a bit. Now, for the adrenal hormone functions, I have no idea why this was placed last in the lecture. For me, it makes a lot more sense to put it in the beginning. Yeah, so I've just moved it here. Think of it as a bit of a preview. It's going to help you understand the later slides a lot more. Now, for the functions of these hormones, first of all, let's talk about our major mineralocorticoid. What did we say it was? Aldosterone. Again, it's not the only mineralocorticoid. Uh, its main function is to regulate electrolyte balance. So what are we talking about that? This means that we're controlling our fluid and ion changes in the body. Specifically, what it really likes is sodium. It really likes taking in sodium, reabsorbing sodium, specifically in the kidney, and it will promote the excretion of potassium. So one thing that I want you to keep in mind is, you probably know this by now, but wherever sodium goes, water will follow. And sodium, think of it, if it's being reabsorbed, this means that I'm also retaining a lot of fluid. I'm retaining a lot of water. So this will allow me to increase my blood volume. And in case of a hypotensive person or someone with low blood pressure, this will increase their blood pressure, helping basically its function, sodium reabsorption, and this will allow for fluid retention. Now, for potassium, it will do the opposite. It will excrete potassium. So while it is absorbing the sodium, it will be excreting this potassium. So in someone with hyperkalemia, if they were to have an increase in aldosterone, this would cause for the excretion of potassium, getting them back to baseline levels. And it does the same thing for hydrogen ions. Keep these in mind because they're going to be very relevant clinically and in the cases that we're going to be discussing later on. Now, this is just a bit of a detail. I don't think you'll be asked about it, but I just put it in for the sake of completion. So how exactly it does it is by multiple ways, but one of the ways is in the distal tubule and collecting duct of the kidney. It's going to basically, it's a steroid hormone. So this means it's made from a lipid. We're going to be discussing that in a bit. And this means that it can go and bind wherever it wants. It can either at the cell surface, either intracellularly, or either in the nucleus. All of this is just for it to increase transcription or the expression of certain proteins and channels. One of those channels is the sodium potassium pump and the Na potassium and chloride cotransporters. Honestly, don't really worry about it. But again, like we discussed, everything expands the extracellular fluid volume. Sodium is reabsorbed, fluid will follow. This will cause fluid retention, an increase in the blood volume or extracellular fluid volume, and might cause hypertension too, in case of an excessive increase of aldosterone. And excretion of hydrogen ions, which means that if we were to have too much of aldosterone, this would cause for alkalosis. I hope that made sense. Now we'll go to the major glucocorticoid, which is cortisol. Again, it's not the only one, but when we're talking major, mainly I believe we're talking about potency, or the final main steroid in the pathway. It's the body stress hormone. Now, when we're talking stress, we don't just mean stress, the one you face in exams. It also means, how can I say this, power or getting you ready for the day. We're going to be discussing it more later on, excuse me, but it basically increases blood sugar. Now, cortisol has a lot of functions, which is why in the next slide we will be discussing them more. But again, the top function of cortisol, when someone asks you about it, is increased blood sugar. It has a very high effect on it because it increases it in multiple ways. It doesn't have just one way where it could increase the blood sugar and suppresses inflammation. This will also be a bit more relevant. Now, for androgens or gonadocorticoids, specifically DHEA, androstenedione is another one. They're basically weak male hormones, like I've mentioned before. And again, they're going to be created in an adult male or female, and peripherally in tissues, they get converted into testosterone, which is a more potent male sex hormone. Now, again, they don't make a lot of sense for a male. They don't depend on DHEA. In adult life, females, it will be responsible, in an adult female, it will be responsible for secondary sex characteristics. What do we mean by secondary sex characteristics? Is basically axillary hair, pubic hair, libido, or like basically sex drive. All of these basically secondary sex characteristics are going to be seen in females, and this is due to a function of a weak male hormone, which is DHEA. And again, puberty for both females and males, but specifically, it has a very important function in very early development and into the differentiation of how the genitalia and organs will look like. So we'll be talking about it in a bit. I just want to mention that the DHEA part, the presentations of its imbalance, are going to make a lot more sense after you guys went through the repro part of the block. So I definitely recommend that you come back to this lecture after you've went through repro, and everything will make a lot more sense because you just know the pathways of sex hormones a lot more, and you know the development and how it plays a role. So for now, if you don't really get it, that's fine. Just make sure you come back and understand it really well. Now for cortisol. Again, I told you it has a lot of functions, which is why I created a separate slide for it. And this is the entire list. We'll go through them one by one, specifically in the inflammatory and immune responses. Some of them are a bit advanced for you guys. You guys will take them a lot of detail in POD, but just have a brief overview just to, make sure that you're on the safe side. Now, the first function is appetite. It increases appetite. Excuse me. It increases appetite. Is this major, or do we care about this a lot? Not really. Now, it also increases blood pressure. Now, the way it increases blood pressure, let me brief you a bit. So we have alpha receptors. I hope you guys know by now. Alpha receptors that are found on the surface of the vasculature of the body, the arterioles. They have receptors, and they're called alpha-1 receptors. The alpha-1 receptors bind the epinephrine and norepinephrine, and after binding of the epinephrine, it's going to cause for vasoconstriction, right? Now, cortisol won't cause direct vasoconstriction. It's going to bind to the receptors to increase the sensitivity of the receptor, or the receptivity of it, to epinephrine and norepinephrine. Basically, it will act as a buffer or an amplification to the effects of norepinephrine and epinephrine. So I hope you guys got that. Now for aldosterone, at very high concentrations, cortisol will bind to aldosterone receptors. Now, why is this relevant? Is because in patients with very high cortisol, you're not only going to find that they have hypertension because of this function of amplification of norepinephrine and epinephrine receptivity on the alpha-1 receptors, but you'll also find that when it binds to aldosterone receptors, again, I want you to recall what are the aldosterone effects. It's going to be a major reabsorption of sodium and fluid retention, which means that at very high concentrations of cortisol, it will cause aldosterone effects, which is basically it's going to cause fluid retention. Hope that was clear. Now for insulin resistance. Again, remember how I told you that cortisol's like main, very, very cliche or basic function is going to be increasing blood sugar. Why? Is because it does it in multiple ways. Now let's discuss them. It's diabetogenic. What does that mean? This means that it will literally, when you have glucose in the blood, if cortisol is there, it won't allow for the uptake of that glucose into the cells, meaning that the glucose will remain in the blood and, make a high blood sugar. This will make it with time, if you have a very chronic elevated cortisol, it could lead you to diabetes. So this is why it's called diabetogenic. It leads to insulin resistance. You guys will understand what insulin resistance more is in the next lecture, but again, making it diabetogenic, which means like it induces diabetes if chronic. Now for gluconeogenesis, again, not only will it not allow for the glucose to be uptaken by the cells, but it will also break down lipids and proteins from the muscle and lipids from stored fat in the body to allow the liver to create new glucose, gluconeogenesis, which means that not only am I not using the glucose that's in my blood, I'm keeping it there, I'm also creating more glucose, making it even more diabetogenic and increases blood sugar even more. So this is why it's a very big function of cortisol. It does it in multiple ways. And for fibroblasts, I hope that you guys by now know that it uses collagen to basically promote wound healing and scar formation. Now, one thing that you'll see in people with very high cortisol is they have this striae. This is just a fancy way to say stretch marks. They have these stretch marks on their abdomen. I'll show you a pic in a bit, but again, this is because the fibroblast, the skin is weak whenever you have any sort of tension or pressure from the inside of the body, namely the abdomen, when you're breathing, when you're, I don't know, whatever mechanical stress you're putting on the skin, on the tissue. Fibroblasts at normal occasion are always working to fix that. They're not working anymore, so that's why you're going to see these striae. And also in a patient with high cortisol, compared to someone with normal cortisol, you'll find that the cortisol patient has a longer period of time to heal a normal cut on their finger. And this is because of the poor fibroblast activity. Now, not only that, but they will have poor wound healing has to do with the inflammatory and immune responses. I'll go through them by one. They might not make a lot of sense, but that's okay. I don't think it's too important. Just keep in mind the inflammatory and immune responses in mind. First of all, it will inhibit the production of leukotrienes and prostaglandins. I'm not sure if you guys went through the pathway, but basically we use phospholipase C to create these leukotrienes and prostaglandins, which are basically chemicals that will allow for inflammation. If I inhibit phospholipase C, I'm inhibiting the entire pathway of production of leukotrienes and prostaglandins, resulting in a decreased inflammatory reaction. Now, for white blood cells, if you guys know from FND that white blood cells, whenever there's an inflammation or a cut or whatnot, they will aggregate, stick to the surface of the endothelium, roll and extravasation, all of that. This process is inhibited. White blood cells can't do adhesion with each other. Now, neutrophilia, it's increase in neutrophils, right? This is just, I want you to think of it as almost a reflex, right? The body is seeing that whenever I'm getting a cut, whenever I'm getting an inflammation, my white blood cells are not aggregating. This must mean I don't have enough white blood cells. So it's going to increase the count of neutrophils, right? It's going to increase neutrophils. So again, it's almost like a compensatory effect because it's realized that the white blood cell adhesion is inhibited. Again, don't worry about it too much. Now for histamine is released from mast cell granules. You guys should know that from FND. Now, this is why cortisol sometimes is used for patients with asthma. Now, with asthma, you have release of histamine. This is going to cause for bronchoconstriction and difficulty breathing. If I am giving cortisol, I'm inhibiting the release of that mast cell histamine and causing for bronchodilation and relief for the patient. So this is why cortisol is used in asthma. Don't worry about this, honestly. And interleukins are just little chemo, like attractants, molecules that are released during inflammation, and this is blocked. Again, all you need to know is for these 2 points, immunosuppression. Now for bone formation, briefly, when we are like in our daily life, we have this process called bone, excuse me. All right, excuse me for that. Again, bone formation. We are technically always in a state of, very brief, and you guys don't need to know this, but a bit of a background is that we are in a process of bone remodeling. What remodeling is just the balance of the osteoblasts, which make bone, balancing with the osteoclasts, which break down bone. They work together to make really strong bones because in our daily life, we have microfractures, we have a bunch of injuries, like micro injuries to our bones, and we want that fixed. This is done by the process of bone remodeling. Now, if I have one of the factors of bone remodeling, which is my osteoblast activity, if I have one of that function decreased, I'm going to result in bones that are weak bone formation. I can't make bones. And we don't have a balance of the breakdown and formation of bone, and this is going to result in a weak bone. And again, you might notice in patients with very high cortisol that they are going to have osteoporosis or osteoporosis-like symptoms, which just means that you have very weak bones. Now, for the steroid synthesis, this is a very big part of the lecture. Again, just make sure my biggest advice here is to memorize the pathway really well of synthesis for all of the hormones. And then when you're solving questions, don't try to act smart and just recall it. Write it down on a paper. It will help immensely. Now for steroid hormone basics. First of all, I want you to know that steroid hormones are made from lipid. They're made from cortisol. You guys are taking well. I think you guys by now know what an LDL cholesterol ester is, hopefully. But again, all steroid hormones are made of cortisol, cholesterol, cholesterol. Excuse me if I said cortisol, are made of cholesterol. Now, where do we acquire this cholesterol specifically? This cholesterol is synthesized in the liver. This liver will then package all of that cholesterol and send it through the LDL. LDL will then go to my peripheral tissues, specifically in my cortical cells or the cells of the adrenal cortex, and they're going to be uptaken for me to then create my steroid hormones. But basically, the blueprint for all my steroid hormones is going to be cholesterol. Where do I get that cholesterol from? LDL esters. Or LDL cholesterol esters. Where does cholesterol come from? It comes mainly from the liver. Now, this is very not major. It doesn't do it very often, but it was mentioned on the slides. So in case of low cholesterol for whatever reason, and the cortex cells need to synthesize these steroid hormones, because these steroid hormones are not stored. You don't have a storage of steroid hormones. They're always secreted on demand. When you need it, it's going to be secreted, which makes sense because it is secreted in bursts. We're going to be discussing that later on. But again, it's not stored. There's no storage for these hormones, so it's secreted on demand. In case I have low cholesterol and I can't wait, I need to create my steroid hormones now because it's made on demand, I would use acetate to create cholesterol, to create my own cholesterol, and then for my steroid hormones. But again, this is not a major thing at all. Now, after I have this cholesterol that goes to my tissues, how will it be carried in my blood? It's carried by CBG, which is corticotropin binding globulin, I believe, and albumin. Again, it will bind to those proteins in the blood and get transported into cortical cells. and be uptaken. Now, one thing that's common among all of the steroid hormones, I'm going to be giving you guys a sort of blueprint to their structure. The first thing is, we said they're from cholesterol, right? This is a cholesterol molecule. Four rings, do you see them? They are labeled A, B, and C. These four rings are found in all of the steroid hormones. This is one thing among all of the steroid hormones, they're going to have this basic structure. Again, one thing that's also found in all of the steroid hormones is, do you see this little side chain of cholesterol? This is not found in my steroid hormones. This is going to be cleaved for all of them. Now, why is that the case? Is because one similar enzyme that's found in all of the layers of the cortex and will undergo through all of the steroid synthesis pathways is going to be cholesterol desmolase. Now, cholesterol desmolase's function is to basically this is my cholesterol, right? I started with it. I'm going to cleave this side chain and I'm going to be having pregnenolone, this precursor. This is the earliest precursor to all of the synthesis pathways, all of the steroid hormones, mineralocorticoids, glucocorticoids, and gonadotropins. So keep them in mind, this specific pathway. It's present in all of them. So that's why when we're going to be discussing the synthesis in a bit, I'm not going to be mentioning it again. Just remember that we always begin with pregnenolone, and it is made by this pathway. We have cholesterol, then cholesterol desmolase, which is regulated by ACTH, will then convert it into pregnenolone. Another thing that's super important about this reaction right here is that it's rate limiting, which means that it takes the longest, basically. And again, regulated by ACTH, which means that when ACTH is secreted, it's going to act on cholesterol desmolase to convert cholesterol and pregnenolone into pregnenolone. So basically, it induces the function of the enzyme. Now, again, this is just repeating. And steroid nucleus, this is basically what we've already mentioned, is that all of the cortical hormones or adrenal cortex hormones are going to be made from cholesterol. And the cholesterol, what structure do we retain from that cholesterol? The four rings. And all of them lose the side chain. Why? Because all of them undergo through cholesterol desmolase to cleave that side chain. Now, all of them also retain the 21 carbon steroid structure except androgens. Androgens do not have a 21 carbon skeleton. They lose the C20 and C21 during their synthesis, and we will be discussing that. Now, these are a bit of like details to the structures of each steroid hormone. Honestly, I remember just memorizing it for being safe. He just put it in, the doctor just put it in, thinking that if you guys understood what structure the steroid hormone is, you would understand the names of the enzymes, or it would make the names of the enzymes easier to memorize. That's kind of true because, again, you have for glucocorticoids and mineralocorticoids, both of them have hydroxyl groups at C11 and C21. But again, when I'm discussing this with you right now, do you know what this means? I don't really think so. So just read those at your own time. Honestly, all I care about is that glucocorticoids and mineralocorticoids are 21 carbon, while androgens lack the C20 and C21 because it gets cleaved. And we will be discussing those a lot more in detail. After discussing the pathway, you read this, you'll understand it. It will make a lot of sense. So now let's begin with the synthesis. Again, we begin with cholesterol desmolase, no matter what enzyme we're talking about. No matter what hormone we're talking about. So again, aldosterone. Now the doctor began with discussing cortisol synthesis first. I began with aldosterone because it makes more sense if you see later on, like after we've discussed on the pathway. So I don't like rearranging doctor slides a lot. I feel like sometimes it makes it more difficult to come back to the original lecture, but inshallah, this won't affect the study at all. Now, again, aldosterone synthesized in the zona glomerulosa because that's the site of mineralocorticoid synthesis. And again, one thing that's very specific about aldosterone is that it's not made in any of the other cortical zones. And we'll be discussing the reason why. Now, first of all, we begin with pregnenolone. I hope you guys know by now, why do we have pregnenolone? It's because of the cleavage of the side chain of cholesterol. Then we undergo this enzyme, 3-beta-hydroxysteroid dehydrogenase. It's a big name, but memorize it. You'll definitely be asked about it. Then you'll have progesterone. After we have progesterone, we have 21-hydroxylase. And again, do you see how this makes sense now? 21-hydroxylase. We've hydroxylated at position C21. So it'll make sense, don't worry. So we have 21-hydroxylase. Then this creates for us 11-deoxycorticosterone or DOC, 11-DOC. 11-DOC is going to undergo 11-beta-hydroxylase to create corticosterone. After we have corticosterone, we'll undergo aldosterone synthase to have aldosterone. Now, why did I circle on aldosterone synthase a lot? Is because this is the exact reason why the synthesis of aldosterone can only occur in the zona glomerulosa, because none of the other cortical layers have aldosterone synthase. And again, you can't stop at corticosterone, you need aldosterone. So this is where aldosterone synthase is going to come in. Again, know the names of these enzymes very well. Now, this is just a repeat of it, but let's look at it on this diagram. So we begin with cholesterol, then we cleave the side chain by desmolase, and desmolase is going to be regulated by ACTH. We're going to have pregnenolone. Pregnenolone then will become converted into progesterone by 3-beta-hydroxysteroid dehydrogenase. Progesterone into 11-DOC by 21-hydroxylase. We hydroxylated at position 21 or C21, and then 11-DOC will be hydroxylated by 11-beta-hydroxylase to become corticosterone. Corticosterone will then undergo through the final step, which is only found in the zona glomerulosa because of the aldosterone synthase to create aldosterone, which is why we can't create aldosterone in any of the other layers. It's specific to the zona glomerulosa. Now, this will make a bit more sense after we discuss cortisol. I'll be back to it. Now for cortisol. Again, the first same step, cortisol cholesterol desmolase. After we create the pregnenolone, we're going to undergo this enzyme. Now, this is a new enzyme, 17-alpha-hydroxylase. It's going to give me 17-hydroxypregnenolone. Again, 17-alpha-hydroxylase, we've hydroxylated at position C17. Do you see that? From pregnenolone to hydroxypregnenolone. Hydroxypregnenolone will then undergo through beta-hydroxysteroid dehydrogenase, the same enzyme that we used in the past reaction in aldosterone synthesis, to create 17-hydroxyprogesterone. Hydroxyprogesterone, 21-hydroxylase to create 11-deoxycortisol. 11-deoxycortisol will then undergo through the final step of cortisol synthesis, which is 11-beta-hydroxylase. Now, let's look at it here. Let's begin from here again. Cortisol, cholesterol desmolase will cleave the side chain to give me pregnenolone. Pregnenolone will then undergo, look here, this is how you read the graph, 17-alpha-hydroxylase, all right? After going 17-alpha-hydroxylase, we have hydroxypreg. Hydroxypreg will undergo 3-beta-hydroxysteroid dehydrogenase to give me hydroxyprogesterone. 21, 11, and then 11-beta-hydroxylase is the last step to give me cortisol. Now, one thing that's important to mention, do you think if we were to have a deficiency in 17-alpha-hydroxylase, we won't be able to make, or we would lose our cortisol effects? The answer would be no. Honestly, for the longest time ever, I couldn't understand this concept, so hear me out here. Do you see this pathway right here? Again, this is in the zona fasciculata. Why is it occurring in the zona fasciculata? It's because we have the 17-alpha-hydroxylase enzyme, okay? Again, keep in mind that whenever we are creating a specific steroid in a specific layer of the cortex, it's because it has the enzyme specifically tailored to do this process. And this is why in the zona fasciculata, we can create glucocorticoids because we have the 17-alpha-hydroxylase. Now I've blocked 17-alpha-hydroxylase. I don't have it for whatever reason, a deficiency. Do you think that I will lose my cortisol effects? The answer would be no. Now, I want you to look at it here, right? We started with cholesterol desmolase, progesterone, deoxycorticosterone, and corticosterone. Remember how in the first slide I had cortisol and corticosterone both as glucocorticoids? And this is exactly the reason why I won't be losing my cortisol effects, is because corticosterone can still be synthesized. Can be synthesized in the zona fasciculata. Notice how up until here, all of these enzymes we have them in the zona fasciculata. We have these enzymes. It's possible to undergo through this pathway to create corticosterone. This process can occur in the zona fasciculata, which means that if I don't have 17 alpha hydroxylase for whatever reason, and I can't do this reaction, I can simply do the corticosterone reaction and create corticosterone. Now, namely, corticosterone is slightly weaker than cortisol, but the body will make up for it and create more corticosterone. This is why, in case I have a 17 alpha hydroxylase deficiency, my cortisol won't be affected. Cortisol effects won't be affected. Realistically, if you were to take a blood sample or a saliva swab, whatever it may be, and measure cortisol, you'd have a decrease in cortisol. But cortisol effects, they're not going to be lost, which is why here they've said that 17 alpha hydroxylase step block won't have deleterious effects because you still could create corticosterone and you can sustain life just fine because you have these enzymes, the 3 beta, the 21 hydroxylase, 11 hydroxylase in the zona fasciculata. I hope that made sense. Now let's go back to one more point. The zona glomerulosa does not produce glucocorticoids. Now this makes a lot of sense right now, right? The zona glomerulosa, we said it can't create glucocorticoids. You might be asking, okay, why don't I just make both aldosterone and corticosterone or pump it out from the zona glomerulosa? It's such a mishwar to have 2 layers. The reason is because right corticosterone does have the cortisol functions, but the problem is I have aldosterone synthase that's only found in the zona glomerulosa. This means that as long as I'm creating corticosterone in the zona glomerulosa, it's going to get converted into aldosterone. Halas, the enzyme is here, it's going to convert corticosterone. It's not going to leave it to just be corticosterone. It's going to get converted into aldosterone, which is why it's not possible to create anything but mineralocorticoids in the zona glomerulosa. Another reason is that we don't have 17 alpha hydroxylase in the zona glomerulosa. You just don't. So you can't do the pathway to then become cortisol. So it's not possible to create glucocorticoids. Again, look at it here. I don't have 17 alpha hydroxylase in the zona glomerulosa. This means that I can't just do this pathway to create cortisol. I hope that made sense. All right. So that basically is cortisol synthesis. Now let's go for androgen synthesis, which is the last steroid hormone synthesis. Again, cholesterol desmolase. Did I miswrite that? Cholesterol desmolase. Again, desmolase enzyme cleaves the side chain of the cholesterol and then creates for me my pregnenolone. Now, one thing that's not common among androgens in structure compared to the other steroid hormones is the lack of C20 and C21. We'll find out now why. Okay, you have preg, and then 17 alpha hydroxylase to hydroxypregnenolone, right? We already know this step. From hydroxypreg, we have 1720 lyase. This enzyme from the name lyase, you're going to basically do lysis or cleave the C20 and C21 carbons off of the cholesterol or the pregnenolone that I have, right? I've cleaved that. So this makes it different from other steroid hormones. They don't have the C21 chain. They have a loss of the C20 and C21 carbons. This will give me DHEA. Now, DHEA in of itself is an androgen, but I could convert it further by 3-beta-hydroxysteroid dehydrogenase into androstenedione. Now, androstenedione is still weak. If I want to create it into a more potent androgen, I want to create it into testosterone, right? So I'd undergo 17-hydroxysteroid dehydrogenase. This enzyme was not mentioned in your slides. I've just put it for the sake of completion. So honestly, don't worry about it. Then you'll undergo through it after the repro part. Again, go back to this after repro. Then you'd have testosterone. Testosterone, again, this will be mentioned in repro. The doctor didn't discuss it, but if you do aromatase, you can convert it into estradiol. Now, again, this is the pathway right here. We begin from cholesterol into pregnenolone by desmolase, 17-alpha hydroxylase. Then we could do either hydroxypregnenolone or hydroxyprogesterone. I could do both of these. These can both be precursors. If I begin with hydroxypregnenolone, or basically I begin from this pathway, cholesterol, pregnenolone, hydroxypregnenolone, I can have DHEA, right? by 17 alpha hydroxylase. How do I reach DHEA? After 17 alpha hydroxylase, I'm going to use the 1720 lyase to get DHEA. Or I could begin from here. Cholesterol, pregnenolone, progesterone, hydroxyprogesterone by 17 alpha hydroxylase, 17 alpha hydroxylase again, and then 1720 lyase to give me androstenedione. Do you see how I can begin either from hydroxypreg or hydroxyprogesterone? Both I could use 17 alpha hydroxylase, then 1720 lyase to give me either DHEA or androstenedione. And again, remember that hydroxypreg will give me DHEA, and hydroxyprogesterone will give me androstenedione. And then I could use another enzyme to have testosterone. And then from testosterone, I can maybe use aromatase to have estradiol, or I could use 5-alpha reductase. Again, don't worry about these. They will be mentioned in repro. But 5-alpha reductase will give me DHE, dihydrotestosterone, which is basically a weak form of testosterone. Now, this was kind of briefly mentioned before. We've spoken about this, that in males, adrenal androgens, they don't have a lot of significance because in an adult male, the testes will produce their own testosterone. And testosterone is a lot more potent than DHEA or androstenedione. So, cholesterol, it's synthesized from cholesterol, and it does not require the adrenal precursors. We don't require any of these, but it's still made from cholesterol. We just don't require this specific pathway or this specific pathway in the adrenal cortex. We don't require the adrenal cortex to create for us our androgens in males. However, the adrenal cortex does have a major function in creating the androgens in females and in early development. Now, this is something that's important, and I didn't want to discuss it earlier on because the pathway was not complete and it was going to be a bit confusing. Now, I hope all of this makes sense by now, and you know that in the zona glomerulosa, we have these enzymes plus aldosterone synthase, and the lack of 17-alpha hydroxylase. In zona fasciculata, we have all of these enzymes, right? Except we don't have aldosterone synthase. This is very specific to glomerulosa. But we also have 17-alpha hydroxylase. In zona reticularis, we only use 17-hydroxylase. Wait, cortisol desmolase, first of all, you know that it's in all of them. But in the zona reticularis, we have the 3-beta-hydroxysteroid dehydrogenase, 17-alpha hydroxylase, the 1720 lyase, and yeah, that's pretty much it. These are the enzymes found in the zona reticularis. Now, if I were to have a block at the 21-hydroxylase state, do you think I'd have loss of aldosterone function? The answer would be no. Now, I'd have, again, just like cortisol, if you were to mention and measure it in the serum, you'd see low aldosterone. But aldosterone effects won't be lost. You'd still be able to retain salt, retain fluid, and excrete my potassium and hydrogen. Why is that the case? Because here, right here, the compound 11-deoxycorticosterone and corticosterone both have the activity of a mineralocorticoid, which means that if I were to have a block at 21-hydroxylase stage, or at 11-hydroxylase, or at aldosterone synthase, I won't beyond 21-hydroxylase. So if I were to have basically a block of aldosterone synthase or an 11-beta-hydroxylase, I won't be affected because I can still make 11-DOC and corticosterone, right? But if I were to have something above 21-hydroxylase or 21-hydroxylase, then I won't be able to make DOC. خلاص, I don't have la DOC, ولا corticosterone, ولا aldosterone. So I would have a loss of my aldosterone effects. But remember, if it's beyond the production of 11-DOC or after 21-hydroxylase, I won't be affected. I can still create aldosterone-like effects by the 11-DOC and corticosterone. The aldosterone effects won't be lost. I hope that made sense. Now, there's one piece of information that I just skipped over. I think it's very low yield, but just memorize it. It's metirapone. It will inhibit 11-beta-hydroxylase, which is the last step in cortisol synthesis. But as we see, 11-beta-hydroxylase is also found in aldosterone. Now, if I were to inhibit 11-beta-hydroxylase, do you think I'd inhibit aldosterone effects? The answer would be no. I still have 11-DOC. But again, you would inhibit the formation of cortisol. And can you inhibit the formation of corticosterone, do you think? The answer would be yes. Because again, look at the pathway here. We said that all of these enzymes are found in zona fasciculata. I stop at 11-DOC. I can't create corticosterone. So I'd have loss of cortisol effects. And you have another drug, which is ketoconazole. It will inhibit mainly the cholesterol desmolase. However, it can inhibit multiple other steps. You don't have to worry about it. Now, this is the basic bulk of why we are discussing this whole pathway. They're almost never going to ask you about a direct precursor. Tell me the pathway. They're never going to do that. They're going to test your understanding of the pathway and what's important about it by the clinical applications of it. So let's discuss it one by one. Let's begin with 17 alpha hydroxylase. We kind of discussed the most of it. First of all, what did we say? We said that it's not found in zona glomerulosa, which is why zona glomerulosa can't create glucocorticoids. Zona fasciculata has it, and zona reticularis has it. All right? So zona fasciculata, we've blocked 17 alpha hydroxylase. Will we have a decrease in cortisol? The answer would be yes. And we've said that we have a decrease in cortisol, as you can see here, but cortisol effects won't be lost. Or maybe they'd be slightly decreased, but we can still compensate by creating corticosterone. What about mineralocorticoids? Let's look at it. It won't be affected. Why? Because again, as we said, 17 alpha hydroxylase, it's not found in the zona glomerulosa. But why is it increased is the answer. Look at it right here, okay? You have 17 alpha hydroxylase blocked. This is the main pathway you're going through, right? Aldosterone. In case I were to have in the zona glomerulosa too much pregnenolone or progesterone, usually I could use 17 alpha hydroxylase to either shunt into the zona fasciculata or reticularis to create DHEA and cortisol. But in this case, I have loss of the 17 alpha hydroxylase. This means that I'll have overproduction of aldosterone. I hope that made sense. And again, if I have overproduction of aldosterone, my blood pressure will increase. Now, serum potassium. This again goes back to the aldosterone effects. I'm going to have a decrease in potassium. Why? Because again, I'm excreting potassium and I'm increasing the uptake of sodium, which is why I'm going to have fluid retention, high blood pressure, and a decrease or hypokalemia. Androstenedione, again, you've inhibited your 17 alpha hydroxylase. You can't do your pathway. I'm not going to have androstenedione or DHEA. They're going to be decreased. So what would this look like clinically? Now, in a male, again, I told you that in adult males, it doesn't matter. However, in early development, this is what's going to happen. Ambiguous genitalia and undescended testes. Now, ambiguous genitalia will make a lot more sense after repro lectures, but basically, essentially, we begun, both males and females, with very similar genitalia structures. And after the effect of certain hormones and certain structures and certain genes, we would have the differentiation of the organs and we'd have the final form. But again, if they were to have ambiguous genitalia or genitalia that you can't really tell it's the genitalia of a male, then this would be due to the defect of androstenedione and DHEA. And undescended testes. So again, the descending of the testes during development is going to be the function of DHEA and androstenedione, the weak androgens. I don't have that, so this will be the presentation. And what about in a female? Okay, she might not have as severe as males, where it's like ambiguous genitalia and undescended testes. She would have a lack of secondary sexual development. What would that mean? This would mean that when you look at this female, she's going to lack pubic hair, she's going to lack axillary hair. You'd see that she's not going the normal puberty stages that other females are going through. She's going to look basically a bit less, how do I say this? She basically lacks the secondary sex characteristics. She is not going to have any libido. Like basically all of these characteristics that in an adult female would be due to this weak androgen activity, she's going to lack that. But again, most important here is the undescended testes and ambiguous genitalia in males. And of course, the high blood pressure. Now, what about 21 hydroxylase? This is the most common and it will represent or show up with a very severe presentation. Let's look at it. So here, 21 hydroxylase. Now, remember how we discussed this? Remember how if we said beyond 21 hydroxylase, we'd be good for aldosterone effects. But if we block 21 hydroxylase, خلاص, you stopped at progesterone, You can't create 11-DOC, ولا corticosterone, ولا aldosterone, so you would have a low blood pressure. You've lost all your aldosterone effects. You don't have anything else to supplement aldosterone. So this is why you're going to have a decrease in mineralocorticoids and decrease in blood pressure. And again, notice how your potassium is going to be increased. Again, the function of my mineralocorticoid. What about cortisol? Cortisol, let's look at it here. 21 is blocked. I can't create cortisol, right? And even in the alternative pathway to create corticosterone, a block, I can't create corticosterone. خلاص, I've lost my cortisol effects, which means what will I have? Here, it would be a decrease in blood pressure. Here, it would be hypoglycemia, which means low blood sugar. And what about sex hormones? They're going to be increased. Why is that the case? Okay, I've blocked my 21 hydroxylase, which is found in both glomerulosa and fasciculata. It's not in reticularis. But my 17 alpha hydroxylase is working, which means that everything I'm creating when I wanted to create my glucocorticoids and mineralocorticoids is going to end up as DHEA and androstenedione, which means that I'm going to have a very high amount of weak androgen, right? Compared to all of the other steroid hormones, which are going to be severely lacking. Don't worry about treatment, it's going to make sense later. But again, you're going to see high hydroxyprogesterone, the precursor. You're going to see high pregnenolone and progesterone because these are the precursors, and simply my 17 alpha hydroxylase is working, I'm going to convert it. خلاص. So this is the most common type of deficiency out of all of these and presents in infancy as salt wasting. What's salt wasting? This right here, the mineralocorticoid effect, or childhood precocious puberty. Now, in males, what will this look like? This will look like in an early like childhood. When we're looking at this male, they're going to be compare them, let's say, at 8 years old, while all of their other friends or classmates are starting to get this male characteristics like low voice, enlargement of the testes, axillary and pubic hair. This male won't have that. They'll have that lacking. Basically, they're not going through puberty. For females, what will this look like is virilization, which means that she is, excuse me, oh my God, my bad, I messed up, I misspoke. I meant that they're going to be going through early puberty. My bad, excuse me. They're going to be going through early puberty. In males, it's going to be undergoing through early puberty. Now, in females, what will this look like? It will look like virilization. Essentially, what virilization is male characteristics in a female that's 8 to 9 years old. So this means that what will this mean, or what will this look like? So it's going to look like when she is compared to her other counterparts or other females her age, she's going to have more axillary hair, while other females haven't developed that yet. She's going to have basically acne. Maybe when she's an adult, she's going to have male pattern baldness. Maybe when she's older, she's also going to have facial hair, right? So these are secondary male characteristics found in a female. This is called virilization, and they present early, which means that around 8 to 9 years old, this female is going to start having these secondary male characteristics. And again, in males, it's going to be early puberty. Excuse me for that mistake earlier on. Now for 11 beta hydroxylase, this is the last step of cortisol synthesis. And aldosterone, now we've discussed, not only does 11-DOC have the effects, but also corticosterone and aldosterone, all of them have aldosterone effects. Now, I've blocked at 11 beta hydroxylase. Will I lose my aldosterone effects? The answer would be no. Now, notice how in labs, when I'm doing it, aldosterone, it's going to be decreased. It's not there in the blood, but I still have high blood pressure. Why do you think is that? Because I have a lot of DOC. Again, 11-DOC will just take in and do the function for aldosterone, which is why I'm going to have a high blood pressure. Now, for cortisol, it's the last step of cortisol synthesis in both normal cortisol and corticosterone. I can't create la corticosterone or cortisol. This is going to result in a severe deficiency of cortisol. What about the sex hormones? 17 alpha hydroxylase is working. The 3 beta hydroxysteroid dehydrogenase is working. There's no reason for me not to shunt into the DHEA pathway, which is why they're going to be increased. Blood pressure, again, makes sense for the mineralocorticoids, same for potassium. Again, renin activity, don't worry about it. We'll discuss it in a bit. Virilization. Again, why is that so? Because we have an increase in the sex hormones in females. This is going to result in secondary male characteristics in a female, and again, at an earlier onset compared to her other female counterparts. Memorize these. Now, the reason why these might be confusing and why this occurs here but not here is because it all is a matter of severity. So depending on the enzyme that you block, you might have different or more severe or less severe effects. So just memorize these effects for each of them. And again, these levels of the enzymes, these levels of the steroids are going to make a lot of sense if you just have memorized this pathway really well. So I hope all of this made sense. This is very high yield. Spend time on it. It might be a bit confusing at first. I hope I've cleared up some of the confusion around it. Now, defects in adrenal steroidogenesis. This is just basically words. It's everything we've discussed put into words. Now, congenital defects. Again, this is just a point that will make a lot more sense later on when we're discussing the defects. But if you are born with a defect in one of your steroid hormones, right? If you were born with, let's say, a 21 beta hydroxylase deficiency, what will this result in? Let's look at it. 21 hydroxylase deficiency. Notice how you're, excuse me. Basically, these are adrenal defects. They're congenital, so you're born with it. Now, let's say congenital. I'm born with low cortisol and low aldosterone. This is going to stimulate, and again, I told you this will make a lot more sense when we're discussing regulation, but this will stimulate my pituitary to release ACTH. Now, ACTH has this function of when it's released in very high forms to act on my adrenal gland, it's going to cause for hypertrophy. Hypertrophy is just basically a fancy way to say that the adrenal gland has become bigger. It has increased in size. So this is what's going to be seen in these patients. When you have a 21 beta hydroxylase deficiency or any deficiency that's affecting my cortisol and aldosterone, I'm going to notice that I'm going to have hyperplasia, adrenal hyperplasia. The reason being is that I have a lot of ACTH production or stimulation. It's going to be in excess. It's going to result in a very large adrenal gland. Now, let's discuss, checkpoint, first of all. So let's see how you can solve a question here. So first of all, female presents with primary amenorrhea and ambiguous genitalia. Now, on examination, she has hypertension and hypokalemia. What does this give us? This gives us an effect of hypertension. So this means that I have high aldosterone, hypokalemia, high aldosterone, low potassium. Now, the laboratory findings show 11 DOC and 11 deoxycortisol levels. What does this mean? This means that, again, remember the pathway? Remember the pathway right here. So I have high DOC. You can reckon right here, just from that one word, that you either, first of all, from reading the question from the beginning, you first of all saw aldosterone effects. Hold your brakes down before you say that it's aldosterone. Read the rest of the question. It said that there is an increase in DOC. Okay, increase in DOC. What case would I have an increase in DOC? Right here, if I were to block 11 beta hydroxylase. Let's look at the other things. 11 DOC. With decreased cortisol and aldosterone. They told you right here that it's decreased aldosterone, but I still have aldosterone effects and cortisol is decreased. Again, cortisol and both corticosterone. The last step is going to be one enzyme, which is 11 beta hydroxylase. So this will give us that her deficiency is indeed 11 beta hydroxylase. Does this make sense? I hope it did. So basically, you must go to the question one by one. If one of the symptoms didn't make sense, they'll probably give you other symptom and you're going to be able to find the deficiency. Again, it needs a lot of practice questions from books, preferably, and then just do a quick pass over the past questions, just to notice which past questions are the best to notice which domain or which area of the lecture is specifically liked and most asked about. But for actual practice, go to books, please. Now we will be discussing a bit more details. Now, cortisol. Cortisol, let's discuss its regulation and secretion. And yeah, so first of all, we have cortisol. What is it? How is it secreted? It's secreted in a diurnal, which means daily. Daily, we are secreting this cortisol. Again, remember that steroid hormones are made on demand, which means that I'm creating this hormone daily, right? And I'm secreting it in a pulsatile manner. Notice how it's not one straight line, it's in pulses, right? Because you don't secrete it all at once, you just create a pulse after a pulse after a pulse. Now, if you notice or follow through the pattern of this pulse, the most important is around the area of sleep, just before you sleep and right before you wake up, right? Keep that in mind. Just before you sleep and right before you wake up. Now, what will the levels be? Just before you sleep, it's going to be the lowest cortisol. So this means that if I want to measure the lowest cortisol ever during the day, it's going to be just before sleep. Now, what about right before I wake up? Why did I mention right before I wake up? Because right before you wake up, the body will spike cortisol or release a very intense pulse to basically get you ready for the day. So this is right here what we see. Right before sleep, you're going to have a very low cortisol because it's trying to calm you down. You wouldn't want a high blood sugar and energy before you sleep. And right before you wake up, the body will get ready by giving you a bit of a spike in cortisol. And again, you're going to see the highest spike there at around just before you wake up. And again, if you notice that cortisol, okay, what controls cortisol? Cortisol secretion. It's mainly ACTH. So this means that ACTH and CRH will also have a very similar pattern of secretion because when ACTH gets secreted, I'm again acting on my adrenal gland and secreting cortisol. So they're going to have the same pulsatile manner and the same levels, basically low before sleep, high just before waking up. This is true for ACTH, CRH, and aldosterone, because again, aldosterone is going to be controlled by all of these. Now, what about the regulation of the hormone? And this is super important. First of all, let's use this graph. Let's not go through all the words. First of all, you have the higher centers, whatever it may be. You don't have to worry about it. You have the hypothalamus. Hypothalamus releases CRH. CRH acts on the anterior pituitary and then gives me ACTH to act on my adrenal cortex. Now, the adrenal cortex will be pumping out my cortisol, my aldosterone, my DHEA. But again, the most important here that we are going to be talking about are cortisol and the zone of fasciculata and reticularis function, which is basically cortisol and DHEA. Why is that the case? Is because aldosterone has a specific regulation mechanism, which is the RAS system, renin, angiotensin, aldosterone system. You guys are well acquainted with it now after renin. But again, so who has the most control or feedback on the pathway of regulation is going to be cortisol and DHEA. But cortisol, if it's really high in the blood, this is going to be sensed by my anterior pituitary and the hypothalamus, which means that the hypothalamus will put the brakes down on CRH and will stop releasing it. And anterior pituitary will also stop releasing ACTH. And because I don't have CRH, I won't be able to release ACTH. But again, you inhibit both the anterior pituitary and the hypothalamus. You don't want to release any of that. The adrenal cortex will then cessate the production of cortisol, and I'm trying to get my serum cortisol levels back in check. But again, who's sampling back to the hypothalamus and anterior pituitary is cortisol. Cortisol is constantly being sensed. If it's really high, I'm going to deactivate or inhibit the production of CRH and ACTH. I hope that made sense. Now, again, as we said, the zona glomerulosa has a different regulation, right? You can regulate it a bit with ACTH, but the most important is the RAS system. That's what controls my regulation for aldosterone. And again, the negative feedback regulation, it's the exact same thing that we've discussed. Cortisol inhibiting hypothalamus and anterior pituitary. Now, the aldosterone secretion. Now, bear with me. Let's look at this diagram. It's a bit overwhelming, but step by step. So first of all, let's begin at the kidney. The kidney, let's say that it has a decreased amount of blood volume coming to it. Or again, we know that there's chemoreceptors in the kidney. It senses that there's a decrease in salt and a high increase or hyperkalemia in the blood. What will it do? It will release renin. After renin is released, I'm going to induce a cascade that's going to create for me angiotensin. Angiotensin will then go to the zona reticularis. Excuse me. Zona zona glomerulosa. Excuse me. It's going to go to the zona glomerulosa to create aldosterone. Aldosterone will then cause its effects, meaning that my kidney has given feedback to my glomerulosa to create aldosterone. Now, aldosterone will do its effects, and it's basically going to cause for hypervolemia or increase in the ECF volume, and it's also going to increase the amount of salt and decrease the amount of potassium, fixing basically whatever it sensed in the kidney. Now, not only that, but the decrease in sodium and potassium is basically sensed by the zona glomerulosa itself. In of itself, it will sense my sodium and potassium. So if it sensed a very low sodium, it's going to also secrete aldosterone, okay? ACTH will also act on it, but again, as we said, the most important for the regulation of zona glomerulosa is going to be my RAS system, which is renin, angiotensin, aldosterone. And again, we have the direct stimulating effects coming from the sensation of the zona glomerulosa to the levels of sodium and potassium in the blood. I hope that made sense. Now, what about inhibitory effects? This would be from AMP. Now, the heart again has pressure receptors and whatnot. When the atria are receiving the blood at a very high pressure or a very high volume, it's going to sense that I need to lower the blood pressure. I'm receiving it at a very high pressure. This is not good. What will it do is it's going to release AMP, atrial natriuretic peptide, right here. It's going to release AMP. Now, what AMP will do is it's going to go to my zona glomerulosa and it's going to inhibit the release of my aldosterone. It's going to stop the release of aldosterone, meaning I'm going to stop the sodium uptake and fluid retention and hypokalemia. It's going to stop all of these effects in an attempt to decrease blood pressure or blood volume because it's received at a very high rate. I hope that made sense. I'll just do a quick recap. Again, in the kidney, we sense a low blood volume or a low blood pressure or a low sodium and an increased potassium. This is going to release renin, cause for the release of renin. Now, renin is going to get converted into angiotensin. Angiotensin will then get converted into aldosterone in the zona glomerulosa. Now, I could have that, or I could have directly the serum's low sodium and increased potassium be sensed by my zona glomerulosa, and this will induce the production of aldosterone. Or I could have ACTH at a very minor function to induce my zona glomerulosa to release aldosterone. Now, once aldosterone is released, it's going to increase the uptake of sodium, water will follow. This is going to expand my ECF volume, and I'm going to excrete my potassium. Again, increased blood volume and blood pressure. Now, what about if I were to have way too much blood pressure or high blood volume and the atria of the heart are sensing that, they're receiving that? This is going to cause for the atria of the heart to release AMP. AMP will have a direct inhibitory effect on my zona glomerulosa, and this will cessate the production or stop the production of aldosterone in an attempt to decrease my blood volume and blood pressure. I hope that made sense. Now, this is a very miscellaneous slide. I've just included it for the sake of completion, but it's just to reiterate that steroids are made from cholesterol, and they are lipophilic, which means that they could do all of the ways that a hormone could bind. So it could bind to the cell receptor to create fast responses by secondary messengers like cycling AMP and whatnot, or it could go and enter inside the cell, cross the membrane, and bind to a cytoplasmic receptor. Or it could go directly and not bind to any receptor and just bind directly inside the nucleus, a nuclear receptor. All of these responses, specifically the cytoplasmic and the nuclear responses, are going to go and act on the transcription process inside the nucleus. This is going to cause the increase of certain proteins or increase transcription of certain proteins. And basically, this is its effect. So let's for example, give aldosterone. If aldosterone were to go and bind directly into a nuclear receptor, it's going to cause for what? Transcription and production of more protein. What will I use this protein for? To create more sodium potassium pump, let's say. That's all this slide is about. Now we finished for that, the basically section of synthesis and all about the hormones. We're going to be discussing diseases and adrenal medulla next. Now, these should make a lot of sense after we've studied the pathway, hopefully really well by now. But let's begin. So first of all, let's begin with Cushing syndrome. Now, what's Cushing syndrome? CC, remember it that way. It is an increase in cortisol. Now, there's a variety of causes why you would have a high cortisol in the blood. Let's begin with the most common, which is exogenous corticosteroid use. Now, for whatever reason, maybe if I'm giving it to, again, I said that it has an anti-inflammatory effect or a suppression of the immune and inflammatory response. If I'm giving it with someone with a lot of allergies, maybe someone with, it's used for eczema, right? If I'm using it chronically and I were to use it, if I'm using it chronically, I'm having it from an exogenous source. My body feels that there's a lot of corticosteroid, right, in the blood. So it's going to, again, be feedbacked back into my pituitary and my hypothalamus to cause for a decrease in CRH and ACTH. If I'm decreasing that and I'm not producing any, I'm decreasing, I keep decreasing it in an attempt to decrease this steroid that's cortisol that's found in the blood, this is going to result in bilateral adrenal atrophy. Again, it's coming directly from the ACTH. I am inhibiting it, right? Because I've sensed that I have way too much cortisol in the blood. This is going to result for atrophy of the gland. Because again, like I said, remember that ACTH has a function of the size of the adrenal gland. If I've cessated it for a long time because I'm trying to control this exogenous steroid, I'm going to have renal atrophy. Now, what about primary adrenal adenoma? For primary adrenal adenoma, it's basically a cancer of the adrenal gland. This will result in one hypertrophied gland. Why is that the case? This is because I'm going to be having a decrease in ACTH. Because why? Okay, let me explain it this way. You have two glands, okay? Share this slide would be easier. You have two glands. This gland has a cancer, right? This cancer is causing it to secrete a lot of cortisol, okay? I'm having a lot of cortisol in the blood. Again, what did we say for regulation? When I have a lot of cortisol, it's going to go directly and feedback and cause negative feedback inhibition. I'm going to stop the production of ACTH. If I'm decreasing ACTH, this is going to result for atrophy, right? But one of them has a cancer that's causing for a lot of basically effects and cortisol. So this means that it's going to cause atrophy only of the unaffected gland. So the gland that doesn't have the cancer is going to become atrophied. However, the cancerous gland is still going to be pumping out my cortisol, which is why I'm still going to have a decrease in ACTH. I'm trying to lower this cortisol, but it's not controlled because of this cancer. So this is primary adrenal tumor, which results in atrophy of the non-cancerous gland. Now, what about ACTH secreting pituitary tumor? What about if I were to have this tumor not in my adrenal gland, but directly in my pituitary? This means that I'm going to have a lot of ACTH secretion. If I'm having a lot of ACTH secretion, this is going to cause for hypertrophy. So again, look at it here. So here, in this case, I had the gland directly secreting cortisol من واحدة هيك. It's unattained. From it itself, it's just secreting this cortisol. So this means that it will cause feedback inhibition and cause for atrophy. But again, this one is cancerous. It's not going to be affected. Only the unaffected or non-cancerous gland is going to become atrophied. What about if I were to have it directly from the pituitary gland? This means that my pituitary is secreting too much ACTH. This is going to cause for bilateral hypertrophy. When we have this cancer in the pituitary gland and secreting ACTH and causing for hypertrophy, this is what's known as Cushing's disease. Again, Cushing syndrome and Cushing disease are not exactly the same thing. Cushing syndrome is all of these cases. But Cushing disease is specifically when I have the cancer in the pituitary adenoma causing for ACTH secretion and the hypertrophy of the gland. So again, just to revise, this is the normal case. This is an exogenous cortisol problem. If I were to have a lot of cortisol received exogenously, it's going to be sensed by my pituitary and causing negative feedback inhibition. ACTH is going to decrease, and this is going to cause for my atrophy, bilateral atrophy of my adrenal glands. Now, what if I were to have a cancer directly in my adrenal gland? It's producing way too much cortisol. This will also cause for feedback inhibition in my pituitary to cause decrease in ACTH. But the only thing that's going to be affected is my non-cancerous adrenal gland. And again, it's a whole feedback cycle because I'm still not inhibiting my cancerous thing, my cancerous tumor. It's still producing cortisol. I'm still pumping out no ACTH, causing for the atrophy of the unaffected gland. Now, what about Cushing's disease, where the cancer is directly in my pituitary? This means that I'm going to have ACTH secretion, too much of it, and it's going to be acting on both glands. The glands are normal, but they're receiving way too much ACTH because of the tumor, resulting in bilateral adrenal hypertrophy. I hope that made sense. Now, for the findings, again, it's just going to be high cortisol effects. We already know them very well. Oh, excuse me, I missed one thing. The ACTH increase, sometimes you could have a cancer that's, let's say, in the lungs. It's secreting ACTH. It's known as paraneoplastic, basically, tumor. If this tumor is secreting high amounts of ACTH, it's still going to cause this case, bilateral adrenal hyperplasia. It's just that it's not secreted from the pituitary, it's going to be secreted from a paraneoplastic area, maybe the lungs, right? Again, just keep in mind that Cushing's disease is when we're referring to the specific case of the pituitary adenoma. Now, the findings, again, it's going to be hypertension, weight gain. Why hypertension? Because we have a high amounts of cortisol. Remember, we said at high amounts of cortisol, it's going to have aldosterone effects because it binds to the aldosterone receptor. What about weight gain? First of all, it increases appetite, so that could be a case. But other thing is that you are going to have a lot of fluid retention. And another thing you're going to have, it's diabetogenic, remember. So I'm not having any of the uptake of glucose and I'm having gluconeogenesis. This is going to cause for weight gain. Moon faces, again, it's going to be due to the fluid retention and weight gain, which basically just means a moon face, like a very round face. What about abdominal striae? Again, remember the fibroblast function. I'm not having any fibroblast function, poor wound healing, no scar formation. I'm going to have abdominal striae, or basically stretch marks on my abdomen. Truncal obesity, buffalo hump, again, all of it goes back to the fact that I'm having an increase in my gluconeogenesis and it's diabetogenic. Osteoporosis, again, like we said, it's going to decrease bone formation and immunosuppression because, again, we said cortisol is an immunosuppressant. This is what they mean with pseudo hyperaldosteronism. Again, it's not hyperaldosteronism specifically, it's high cortisol. But because it's binding to the aldosterone receptors, it's going to have aldosterone effects, which is why it's called pseudo hyperaldosteronism. It's basically fake hyperaldosteronism. Now, for the diagnosis, this right here is one of the most high-yield things you could think of. So first of all, I want to see how can I diagnose this patient? How can I find out where exactly this tumor is or where exactly is the problem that's causing for the high cortisol? First of all, I need to confirm if I have high cortisol. How can I do that? Notice when we said that the lowest amount of cortisol is going to be around midnight, right? Or before you sleep. I'm going to take a late night salivary cortisol. If my cortisol is high when I'm at night, this means that, yes, I've confirmed that I have high cortisol or I have Cushing syndrome. Now, I could use a 24-hour urine-free cortisol. Again, just collect the amount of cortisol and check it that's in the urine. Or I could use dexamethasone. Now, dexamethasone just basically suppresses the production of, basically just essentially what dexamethasone is, it's a synthetic, let's say, cortisol. So you'd give a synthetic cortisol and then measure ACTH. Now, I want to measure ACTH. خلاص, I've confirmed that I have high cortisol, right? I will then measure ACTH. I want to find out where exactly is this area that I'm having this high cortisol from. So if it's suppressed by this dexamethasone, if I gave low dose, which is 1 milligram dexamethasone, which essentially is I'm giving cortisol, fake cortisol. If it is suppressed, then this means that my problem, it's not in the pituitary, because if it was in the pituitary, it wouldn't be suppressed. This means that خلاص, I gave cortisol and it was enough to suppress my pituitary. So this means that my problem is in the gland. I have an adrenal tumor, right? So this is where we are going to go and confirm it by CT. Again, the confirmed diagnosis, these aren't really important, they're just there. But again, this means that it's ACTH independent. The problem is not because of ACTH, the problem is because of a tumor. Now, if I measure the ACTH and it is elevated, even after I gave the dexamethasone, the synthetic exogenous cortisol, if it remained elevated, this means that it is ACTH dependent. Right? So this means that I am having this high cortisol because of ACTH. There's no regulation on ACTH. Now, I want to know, is this ACTH coming from an ectopic source or a paraneoplastic area like the lungs, or is it coming directly from the pituitary to diagnose it as Cushing's disease? This is where I do high dexamethasone test. Now, if I were to give it low dose, if I were to give a low dose dexamethasone, it's not going to be suppressed. It can only suppress the adrenal tumor. Now, if I were to give a high dose, this is going to suppress if I have a tumor in my adrenal, as in my pituitary. So if I give high dexamethasone, it can inhibit my pituitary, and I will inhibit the ACTH. If it is suppressed, then I can confirm that this is Cushing's disease. If it's not suppressed, then it's not acting on the pituitary. Then this is coming from an ectopic source. I hope this made sense. So again, let's repeat. First of all, I want to confirm cortisol. Is it high or not? I will do either 24-hour collection, or again, the most high yield to know is that you will do a late delivery cortisol. Why? Because in normal condition, late night, the cortisol should be low. But in this case, in a patient with Cushing's syndrome, they're going to have it high. Or then after, I would give a low dose dexamethasone. What is dexamethasone? It is basically synthetic cortisol. I'm giving synthetic cortisol, right? And then I want to measure ACTH. Now, if it was a problem in my adrenal gland, I'm going to have a cessation of this ACTH. ACTH will be suppressed because I have really high cortisol. It's going to basically feedback inhibit my pituitary. And I'm going to have basically, what is this? It is going to be an adrenal tumor, which means it's ACTH independent. The problem is not ACTH that's causing this high cortisol. Now, if it's still elevated, it didn't get suppressed, this means that it's ACTH dependent. The problem is my ACTH is uncontrolled. It's causing for me high cortisol. So then I'm going to increase the dose of dexamethasone. If I increase the dose of dexamethasone and it is a pituitary tumor or Cushing's disease, it's going to be inhibited. خلاص, I'm going to be suppressed. If it's adequate suppression and I've noticed that my cortisol did go down and my ACTH was suppressed, this means that this is Cushing's disease, or basically cancer in the pituitary. If it's not suppressed, this makes sense. This means that this area is somewhere else. It's an ectopic source of ACTH, like maybe a paraneoplastic lung cancer. Now for CRH stimulation test. This kind of makes sense. The doctor didn't explain it, but let's go through it. So I'm increasing CRH, right? That's from the hypothalamus. It's going to act on my pituitary to increase ACTH. If I've stimulated it and the ACTH did increase and cortisol increase, this is Cushing's disease. But if there is no increase and there's no increase in my ACTH or cortisol, this means that it's ectopic. Because again, if I'm stimulating CRH, this means that I'm directly acting on my pituitary. If the pituitary does increase ACTH and cortisol, it makes sense. This means that this is a Cushing's disease. This is a cancer of the adrenal, the pituitary gland. But if it's not increased, this means because CRH won't act to increase ACTH on an ectopic source if it's in the lung. So this means that it's not Cushing's disease, and we have to look for the cancer, basically. Where is it? The paraneoplastic one. I hope this made sense. I hope it wasn't too confusing. And again, please learn this very well. It's very high yield. Honestly, don't even worry about these, like the consider CT, whatever it may be. Addison's disease or adrenal insufficiency. Now, in this case, I have a problem with both aldosterone and cortisol. Both of them are going to be deficient. Now, in Cushing's, it was a high cortisol. In Addison's or adrenal insufficiency, I have a deficiency in aldosterone and cortisol. Now, I could have it two cases. This deficiency can either be acute or chronic. How could I have acute or very quick onset of this deficiency in aldosterone and cortisol? It's going to be due to hemorrhage. So basically, I had hemorrhage to my adrenal gland. It's not receiving any more blood. The gland is dying. I'm going to be having a decrease in aldosterone and cortisol very, very quickly, very acutely over a short period of time. But if it was chronic, the patient came in with the low aldosterone and cortisol effects and told you that it's been going on for a while, for a very long time. This is what we diagnose as Addison's disease. And this means that we have destruction of the gland itself. It's not a problem in hemorrhage anymore. That will be like something that's very quick. You just bled. This would be something that's very chronic, and it could be by autoimmune cause. It could be by an infection due to tuberculosis. Know these, they might be like little hints while you're solving questions. But again, if it's chronic, this is what we diagnose as Addison's disease. And again, this is primary, right? So this means that we are going to be losing the effects of aldosterone and cortisol at the level of the adrenal gland. All right. Now, what will the effects be? First of all, loss of aldosterone, hypotension, hypovolemia, right? Hyponatremia. Because why? I'm not retaining any fluid. I'm not uptaking any of my sodium. I'm going to have a decrease in that. And hyperkalemia, again, hyperkalemia, low aldosterone. Metabolic acidosis. So notice how I told you that in hydrogen is going to be excreted along with potassium. I'm not excreting it. I'm having way too much hydrogen, which rather than alkalosis, I'd have acidosis. Now, skin and mucosal hyperpigmentation. Why? Because I'm going to be having an increase in ACTH. Now, again, remember the feedback. I'm having a decrease in aldosterone and cortisol. Cortisol is low. My pituitary is going to be sensing that. It's going to pump out ACTH. This ACTH is then not only going to be acting on the defective gland, the gland that's either bleeding, undergoing hemorrhage, or basically destructed because of autoimmune disease or infection or whatever it may be. It's going to be acting on this defective gland, and also it's going to be inducing the promelanocortin production, which means if I want to find out that this is primary, this is at the level of the adrenal gland, then this means that the patient will present with pigmentations that are found in their mucosa and even on the skin. You're going to see how they have this random pigmentation. This can confirm to me that this is primary adrenal insufficiency. And then depending on the tests, I can find out if it's acute or chronic. Again, chronic, it would be over long term, and it would be known as Addison's disease. It would be destruction due to whatever it may be, due to atrophy or destruction, basically by autoimmune disease, infection, whatever it may be. Don't worry about this. You guys didn't take Neisseria or endotoxic shock. This is very POD core. You're not going to be asked about this. Now, what about secondary adrenal insufficiency? And how can I differentiate it from a primary adrenal insufficiency? Now, first of all, it's going to be a decrease in ACTH production. So again, I'm going to have a decrease in ACTH production, which means I'm going to have a decrease in my cortisol. Why did I say only cortisol and not aldosterone? Now, the reason here is because it's not a problem in my gland, in my adrenal gland, which means that my aldosterone, renin-angiotensin aldosterone system is still working and it can compensate for my aldosterone. So, right, my my adrenal gland is not producing is not producing aldosterone, but I could rely on the renin-angiotensin aldosterone system to induce the aldosterone to be produced, okay? But here you have a decrease in ACTH, which one will be most affected? My cortisol. I'm going to have a decrease in cortisol. I'm not making cortisol. Now this will also show as this is the first difference between a primary adrenal insufficiency. The aldosterone will still be compensated for by the renin-angiotensin aldosterone system. You're not going to have the aldosterone effects. what would you have is cortisol. And another thing is no hyperpigmentation or the mucosal pigmentation. Why? Because again, I have missing ACTH. The problem is within the pituitary. So this means that I won't have the stimulation of the promelanocortin. I'm not going to see the pigmentation. So this is how I can differentiate between both. Tertiary adrenal insufficiency is if the patient was taking exogenous cortisol. Again, feedback inhibition. It's going to stop ACTH from coming out, and this will result in withdrawal symptoms. But again, aldosterone won't be affected. Why wouldn't it not be affected? Because I still have the renin-angiotensin aldosterone system intact, and it's going to be compensating for my aldosterone, or it's going to be inducing my aldosterone. Again, just not to get confused, is because the here the adrenal is still working. The adrenal gland is not defective. It's just that it doesn't have a stimulant to produce the steroids. Here, though, the aldosterone has its own system. It can get stimulated by angiotensin and get produced. But that's not the case for cortisol, which strictly relies on ACTH to be produced, which is why you're not going to have your aldosterone affected. And again, you're not going to see the hyperpigmentation. Now, cons, which is the last one we will be discussing for now, it's hyperaldosteronism. Now, hyperaldosteronism, again, it is going to be too much aldosterone being produced from my zona glomerulosa. Specifically, it's going to be a cancer of my zona glomerulosa. What will this result in if I have way too much aldosterone? Now, in normal cases, if I were to have low aldosterone, it could cause death. Like it's very severe. But if I have hyperaldosteronism, I'm going to have these effects. I'm going to have a decrease in my potassium. I'm going to have an increase in my sodium, and I'm going to have an increase in my retention. Notice here how it's going to be alkalosis because I'm excreting way too much hydrogen. And this is, again, this is primary hyperaldosteronism. It won't, okay, this is very important. It won't cause edema because of the escape mechanism. Let me discuss this a bit more. What is an escape mechanism? And why do I not see edema in this case? So when you're having this hyperaldosteronism, if it's primary, you're having way too much sodium being sampled by the kidney, right? And again, sodium will pull water with it. This is going to create a very strong hydrostatic pressure within the kidney. The kidney is sensing this hydrostatic pressure, and it's going to basically push the fluid out. It's going to be, this hydrostatic pressure is going to push the fluid out. I'm going to lose a lot of fluid, and I'm going to lose a lot of sodium, which means that I'm not going to see edema. I'm not going to see this peripheral amount of fluid seen in the tissue. Because my kidney is compensating for it, it senses that there's way too much sodium and water. This will cause for hydrostatic pressure inside the kidney to build up, and this will cause pressure natriuresis. This is what's known as pressure natriuresis. It's the increased blood flow and pressure that's going to promote basically excretion of the sodium in the water, caused by hyperaldosteronism. And again, aldosterone, because I'm increasing a lot of blood flow to my kidney, it's going to increase the pressure among the vessels. This is going to be sensed by the blood vessels, and they're going to vasodilate to kind of compensate for that. So you're not going to see a very high blood pressure. This is known as the escape mechanism, and we see it in primary hyperaldosteronism. But if it's a secondary cause, then you're going to see an impairment of the escape mechanism. Why is that the case? Okay, let's see a secondary cause. So again, in primary hyperaldosteronism, it is a problem in my adrenal gland, and it's being producing way too much aldosterone. I'm not going to have edema, and I'm not going to have very extreme hypertension because of the escape mechanism. Again, because of pressure natriuresis, I'm going to have vasodilation. But in secondary hyperaldosteronism, the problem is within the kidney itself. So an example would be renovascular hypertension, which is basically when you have a stenosis or a blockage of your vasculature of the kidney. Okay, I'm having a blockage of vascular to the kidney. It's not receiving as much blood. To the kidney, it thinks that it's not getting enough blood. It needs to vasoconstrict the vessels to allow for more blood to come in. But this is going to just worsen the effect because I'm still not having any of the blood coming in. I have a stenosis. The problem is within the vasculature itself. I have a constriction. This means that my kidney is still not getting blood, and now I'm hypertensive. And again, it's not going to be fixed because to the kidney, it's doing its job. It's doing what it's supposed to do. It's trying to get blood into it. So this is what's going to be known as renovascular hypertension. What about juxtaglomerular cell tumors, which means that they're going to be producing renin a lot. The problem is within the cells that produce renin. I'm going to be producing a lot of renin, a lot of aldosterone. And this is why you're going to see edema. There's no escape mechanism. The kidney itself is defective. And here, it's an adrenal problem. So the kidney will try to compensate by having pressure natriusis and vasodilation. I hope this made sense. I hope this wasn't too confusing. And again, a checkpoint. Okay. Well, let's solve it. Okay. Presents with resistant hypertension, and muscle weakness. So again, think of potassium. She has a history of frequent nocturia, which means that she's going to the bathroom a lot at night. Laboratory results show hypokalemia, alkalosis, and elevated plasma aldosterone levels. So again, she's basically having all of the hyperaldosteronism effects, and she's going to the bathroom a lot. The renin level is low. Renin is low, which means that, again, my kidney is working fine. It's not a secondary cause. CT scan shows adrenal adenoma. I mean, they already told us this is an easy question. What is the most likely diagnosis? Conn syndrome. Again, I just want to reiterate, I didn't mention it, but Conn syndrome is when it's primary. Secondary hyperaldosteronism is just called secondary hyperaldosteronism. Make sure to know these names. They like to test you on Cushing's disease versus Cushing syndrome, adrenal insufficiency versus Addison's disease. So make sure to know that well. But again, everything is pointing towards it being Conn syndrome, meaning the problem is in the adrenal gland itself. Because first of all, renin is low. She's going to the bathroom, which means that my escape mechanism is still intact. She has hyperaldosteronism effects. All of this will show me that it's Conn syndrome, which means a problem in the adrenal gland itself. It's primary cause. Now we've reached the last part, which is adrenal medulla. It's not going to take a while, hopefully. And it's very easy. Honestly, it has one significant thing that you'll probably be asked about. Otherwise, it's like I'll be just focusing on the highest yield. He mentions a lot of things that are not very relevant, and I'm going to let you know as along the way. All right. Now, the adrenal medulla, we discussed it a bit in the beginning, but it's known as a modified sympathetic ganglion. Now, the reason is because the cells inside of it, the origin is neural ectoderm. Neural ectoderm cells are going to be found, where's another place they can be found? They can be found in the sympathetic chain. What are the cells that are we going to specifically find here are called chromaffin cells. They're going to act as a postganglionic sympathetic neuron. What does this mean? Okay, so basically we have here the preganglionic neuron, okay? It's going to be going to my adrenal medulla and synapsing and releasing acetylcholine. Acetylcholine is then going to stimulate my chromaffin cells, just like it would a postganglionic neuron, and it's going to cause for the release of my epinephrine and norepinephrine. Now, epinephrine and norepinephrine are going to go to the blood vessels, and as we discussed before, they're going to cause vasoconstriction. Remember, who will amplify their effects is cortisol binding to the alpha-1 receptor. Now, this is just a very random miscellaneous slide, but let's discuss it. So first of all, you're going to have an action potential propagating down your axon. This is going to cause for the stored vesicles of norepinephrine and epinephrine to get released. How do they get released? Is because the action potential is going to trigger for intake of calcium. Calcium is going to increase within the cell. It's going to cause for the release of my vesicles of stored norepinephrine and epinephrine, and this is going to bind to my receptors, my adrenergic receptors. This is going to cause for then the secondary effects, cyclic AMP and whatnot, and it could bind on my blood vessels to cause for vasoconstriction. This is pretty much the stick of this. I have no idea why it's here. But the most important here, okay, I was almost gonna forget, but that metabolism of norepinephrine. After we've used norepinephrine and epinephrine, they can either go back and get recycled and put back into a vesicle, or we could break them down in the mitochondria to become what? Monoamine oxidase. By monoamine oxidase, they're going to be broken down. Now, what will they be broken down to? Phenylmandelic acid. Keep this name in mind, okay? So the metabolism of norepinephrine and epinephrine by monoamine oxidase or catechomethyltransferase is going to result in vanillomandelic acid. Keep that in mind. Now, this is the functions of adrenergic receptors. You don't have to know this, honestly. This is very much POD-ish. You're going to learn this a lot in second year. It's not relevant at all, but you do need to know about the functions. Honestly, the entire batch memorized them. Just stay on the safe side, memorize the functions. But again, I'm telling you that you won't be using it much. We're going to be talking about the alpha-1 receptors and beta-2 receptors. All I need you to know for now is that alpha-1, when you bind to it, it will cause a vasoconstriction. But beta-2, when you bind to it, again, both bind epinephrine. If you bind to beta-2, you're going to cause for vasodilation. Keep that in mind. Now, a quick overview of catecholamine functions. Catecholamines being epinephrine and norepinephrine. So first of all, what do they do on the carbohydrate metabolism? They are going to be causing for a very instant rise in blood sugar. They spike blood sugar incredibly quickly. How do they do that? By gluconeogenesis and glycogenolysis, which means they break down glycogen and break down protein, lipids, and fat to make new glucose and decrease glycogenesis. So again, they're going to basically just spike up my blood sugar a lot. And they promote the release of glucose from the liver. Again, all of this to promote my glycogenesis and gluconeogenesis. And furthermore, it will inhibit insulin. Now, we know that insulin will decrease my blood sugar. It will decrease whatever decreases my blood sugar. All of these together are going to cause for epinephrine to cause for a very, very high spike in blood sugar. Where can I use this? Where can I realistically have this function be very good? Is if a patient came in to me with severe hypoglycemia, I need to get them to high blood sugar ASAP, I would be administering epinephrine because look at it, it's basically promoting all of the functions that could increase glucose in the blood and inhibiting any cause that could decrease glucose in the blood. Now, what about lipid metabolism? Again, it's going to enhance it. This makes sense because it does gluconeogenesis. So it's going to just enhance the breakdown and cause for triglycerides to be broken down from the fat that's stored in the body. And again, free fatty acids are going to be increased in the blood. And this is going to be utilized for my heart and muscle to be used as a fuel source. So basically, in case of a very stressful situation, you're going to have these being released to just help you basically, I don't know, run from a tiger or something. It's going to give you the fuel. It's going to give you high blood sugar. It's going to give you fuel by breaking down your fat. Physiologic function, again, what does it do? It's going to go and bind to these receptors. Now, it's going to increase cardiac output, which means that the amount of blood I'm gushing out per pump is going to be very high. It's going to increase my blood pressure because it's going to cause for vasoconstriction. And again, oxygen consumption because it's going to basically cause for you to relax the bronchi. Again, it will cause smooth muscle relaxation in the bronchi. If I have a smooth muscle relaxation in the bronchi, I'm going to allow for more air to come in and therefore higher oxygen consumption. And GIT and blood vessels supplying skeletal muscles because again, it has that function on smooth muscle. Learn these, memorize them, but not very high in my opinion. Now, this is what you will 100% be asked about from the adrenal medulla. This is very important. Now, again, remember how I told you that it's from the neural crest cells. It comes from the neural crest. The chromaffin cells come from neural crest cells. So this specific type of neural crest cell is also found, I told you, in the sympathetic chain. This means that this specific tumor, pheochromocytoma, not only occurs in the adrenal medulla, it occurs wherever there's chromaffin cells. So, for example, in the sympathetic chain, you could find that there's paravertebral. Again, remember where the sympathetic chain ran? It ran paravertebrally, right? So from the base of the skull into the pelvis. Anywhere along there, you have the sympathetic chain and you have chromaffin cells, you could have pheochromocytoma, right? Which is basically a tumor of the chromaffin cells, right? You could have this tumor, and these are a bit of the, I don't know, stats about it. You can memorize that, not very important, but it secretes a lot of epinephrine and norepinephrine. This tumor specifically is localized in the medulla. When it's in the adrenal gland, it's localized in the adrenal medulla, and it's going to cause for a lot of secretion of epinephrine and norepinephrine. Now, the way it releases it is it's not a tonic release, okay? It will release it and stop, release and stop. It releases it in what they call spells, basically. Now, what do these spells look like? Basically, most tumors secrete epinephrine or epinephrine dopamine, which are basically our catecholamines. What will they do? Again, remember the physiological effects, which means they're going to cause for tachycardia or increase in the cardiac output. They're going to cause for hypertension, all of this. So basically, a way you can remember it is by the 5 Ps: pressure, pain, perspiration, palpitation, pallor. All of these are the physiological effects of epinephrine. Now, is it all the time? No, it's in an episodic fashion or spells of this pressure, pain, perspiration, palpitation, pallor. So this is going to be the cause. Also, it can secrete or induce the secretion of my erythropoietin, which is going to result in polycythemia. They're not going to ask about this, but just know in case. Now, again, spells relapse and remit, which means that the patient is going to be coming to you and they're like, I keep on having these episodes of my head really hurts, I breathe really quickly, and my heart rate feels really quick. So all of these are the symptoms. Now, the good thing about this tumor is that you can resect it by surgery. You can surgically remove it. Here's what's most high yield about this case is that when you want to resect it surgically, you need to block your alpha receptors before your beta receptors. Why is that the case? Again, remember what did the alpha 1 receptors do? They caused vasoconstriction. What about the beta 2 receptors? They caused vasodilation. If I'm already having a patient with hypertension, right? This patient came to me with this tumor with hypertension. I block the beta receptors, which cause vasodilation, right? And as I'm resecting this tumor, you're basically squeezing it, right? During surgery, you're squeezing this tumor. It might release some catecholamines in the blood. This is going to cause for hypertensive crisis. The entire body is going to release a surge. This surge of epinephrine is going to be released in the blood and cause for hypertension. This is going to cause for hypertensive crisis. The patient is dead. This is why you must ensure to block the alpha receptors before beta receptors. So basically, a few days before surgery, you want to block your alpha receptors, basically get the patient to have a lower hypertension. So decrease in the blood pressure they have. And then during the actual surgery, I will block my beta receptors to avoid hypertensive crisis. Again, I don't want my epinephrine to act on the receptors at all. It's going to be dumped into the blood in very high amounts. I hope that made sense. Now, how can I diagnose this? I skipped kind of directly into treatment, but findings. How can I find this? Remember how I told you that when we release norepinephrine, it binds to the receptors, and then it can either be reuptaken into the vesicles or metabolized by monoamine oxidase or catechol-methyltransferase. We will have phenylmandelic acid. In a patient with pheochromocytoma, if you were to check their urine, you would have a lot of or a high level of phenylmandelic acid. This is the way we can diagnose pheochromocytoma. I find high phenylmandelic acid, khalas, I know it's a problem of my adrenal medulla. I need to resect this tumor. What will I do? I will prepare surgery. I will block their alpha antagonists. I'll block their alpha receptors by alpha antagonists, and then basically antagonize the receptor. This is a type of drug. And then during the surgery, I'm going to block my beta receptors. Why? Because I want to ensure that all of the epinephrine, while I am mechanically manipulating this tumor as I'm resecting it, any epinephrine that's dumped into the blood, I don't want it to act. Or else I'm going to end up with hypertensive crisis. I hope that made sense. Again, this is everything that we've mentioned, basically in words. Don't worry about the drugs. I just put them for completion's sake. Again, another checkpoint. So his blood pressure, episodic. Again, look, this is the keyword: episodic headaches, palpitations, and sweatings. They're the 5 Ps we spoke about. His blood pressure is found to be 180 over 100, 110. 24-hour urine collection showed elevated metanephrines and norepinephrines. Again, this is basically going to be that your metabolized epinephrine and norepinephrine. And again, when you did CT, again, this question is really easy. It did a CT and showed you directly that there's an adrenal mass. Khalas. After all of these, you must know that this is a tumor of the adrenal medulla and the appropriate treatment. Okay, what would be the appropriate treatment? I hope you guys answered that by this point. But again, it's going to be my alpha blockers. Again, remember A before B. You want to block your alpha receptors because you don't want to cause vasoconstriction. And during the surgery, you're going to block your beta receptors because you don't want any of the epinephrine to bind. That's going to be dumped into the blood. Okay. And that's pretty much it. I know it was quite a lengthy session, and sometimes I went off track, but I hope everything made sense. This lecture is, you need time to spend with it. Even the cases, try to understand why each and every presentation occurs. The things I told you not to worry about, I didn't just say it because I wanted to say it. I said it because it genuinely isn't important, and Dr. Yaqeen sometimes just skips over things and you're not really sure if it will come in the exam or not. Some of these are way too advanced and he didn't even slightly go over them. If you want, go over them for completion's sake. But my biggest advice is after this, definitely go back to the recording, read the slides of the lecture, make sure you understand everything that the doctor says because he's very, whatever he says is coming in the final. Understand everything he says and then practice, practice, practice. Make sure to practice very well on questions and don't try to act smart and just answer from your brain, trying to actively recall whatever the enzyme was. Write the pathway down and it's going to make your life a lot easier. Just write the synthesis pathway down and your life will be a lot easier. Inshallah, this was helpful. Thank you guys so much. And yeah, thank you.